Welcome. This is part one of a two-part video series on COVID-19. Part one, this video, discusses the epidemiology of COVID-19, while part two discusses the pathophysiology and its related signs and symptoms. Epidemiology is the study and the analysis of the distribution patterns of diseases in a population. Now, this could be any disease, it could be in any population. The purpose of the analysis is to decide whether there needs to be an intervention to reduce the spread of a particular disease. In this video, we're focusing on COVID-19. Now, COVID-19 is related to MERS and SARS. All are coronaviruses and all are zoonoses. In other words, they are all infectious diseases transmitted from animals to humans. The initial pathogen circulates in an animal reservoir and then mutates and infects an intermediate host. It mutates again and then infects humans. SARS came onto the scene in 2002, severe acute respiratory syndrome. It's a coronavirus. Its original reservoir was in bats. It then mutated and jumped to masked palm civets, a type of large Asian cat, before mutating again and jumping to humans. 10 years later, MERS arrived, Middle Eastern Respiratory Syndrome. Again, a coronavirus whose original host was in bats. In this case, it jumped to an intermediate host of camels before jumping to humans. In 2019, we encountered COVID-19. Again, a coronavirus, initial reservoir in bats, where it jumped to pangolins, a type of scaled anteater in Asia, before jumping to humans. In all of these diseases, or in any disease, one of the data points that we're really interested in is the case fatality rate. Case fatality rate is computed by taking the total number of cases and dividing that into the number of deaths and multiplying times 100. For comparison's sake, the case fatality rate for influenza is less than 1%, and this is with a vaccine. So keep in mind that SARS, MERS, and COVID-19 do not have a vaccine, and there is no treatment to date. When we look at SARS, there were 8,000 cases and 800 deaths. We do the math, we find out that's about a 10% case fatality rate. Okay, and when compared with influenza, it's significantly higher. Looking at MERS, we had roughly 2,500 total cases and 850 deaths. Doing the math, we find the case fatality rate for MERS was 34%, significantly higher than that for SARS, and obviously much higher than that for influenza. When we try to do the math for COVID-19, we run into a problem. We simply don't know what the total number of cases are, and we don't know the total number of deaths. We do know that the total numbers change somewhat with regions. Home deaths due to COVID-19 are not reported. Over the last couple of weeks, we've learned that many of the home deaths that we originally attributed to strokes and heart attacks were a side effect or a direct result of a COVID-19 infection. We don't have true numbers for the number of home deaths, or therefore deaths that are due to COVID-19. Nor do we know the total number of cases, as many COVID-19 patients are asymptomatic or have minimal symptoms, never go to see a physician, are not tested, and we simply don't know. There are a couple of things we do know. We do know that older people and those with pre-existing health problems have a significantly larger fatality rate than younger people, and that's in general. Other data that is important is the reproductive ratio and the serial interval. The reproductive ratio of any disease is the number of people that one person can infect. So the mean reproductive ratio for COVID-19 appears to be right around 3. That means one person can infect 3 more. And then those 3 people go on to infect 3 more, giving it 9. And then those 9 people go out and infect 3 more, jumping to 27 that are affected within a certain period of time. And then those 27 people each go out and infect 3 more within that given period of time, and suddenly we're up to 81. This continues to jump. The numbers we're seeing here are after 13 serial intervals. So I'll talk about serial intervals in a minute. So when the reproductive ratio is greater than 1, there is an exponential increase in the spread. When the reproductive ratio is equal to 1, there's essentially no increase in spread. One person infects one other person, infects one other person. And if the reproductive ratio is less than 1, the spread decreases and eventually the virus dies out. Now the serial interval is the time frame. It's the amount of time it takes one patient to develop symptoms, infect another person, and for that person to develop symptoms. The shorter the serial interval, the more contagious the virus is. The mean serial interval for COVID-19 is 4 days. That means when one person starts to is infected, starts to show signs and symptoms, and infects another person and they start to show signs and symptoms, is roughly 4 days. Note that a pathogen with a high reproductive ratio and a low serial interval is very dangerous. For comparison, again, let's refer to influenza. Influenza's reproductive ratio is about 1.3, and its mean serial interval is 2 days. So that means it takes only 2 days for one person who has influenza to infect another and for them to show symptoms. So it has a very low serial interval, but its reproductive ratio is also low. So that means you can see the numbers here. Over 13 serial intervals, you're going to end up with a total number of COVID-19 patients in the millions, 2,391,484 versus 185. So that's after 13 serial intervals. But remember that the serial interval for COVID-19 is 4 days and the serial interval for influenza is 2 days. So those days, we need to do a little bit more math. So over 13 serial intervals, the total number of patients after 52 days, okay, that's 13 times 4 gives us 52. So for COVID-19, the total number of patients that we have are 2,391,484. And for influenza, because we need to carry that out because the serial interval is much shorter than COVID-19, when we do the math, it comes out to about 4,075 patients after 52 days. There's a huge difference between the spread of COVID-19 and influenza. That means anybody that compares influenza to COVID-19, there is no comparison. COVID-19, the spread of COVID-19, it is much more contagious than influenza. So here's what we know about COVID-19, and we're still in the early stages. We're still learning an awful lot about it. We know that we don't know the true case fatality rate. We know that the mean productive ratio is 3. We know that the mean serial interval is 4. We know that we don't have a vaccine, and we know that we don't have treatment. We also know that COVID-19 is a respiratory coronavirus that primarily spreads when uninfected people inhale large respiratory droplets containing the virus. Most of these droplets are caught by the mucous membranes in the throat, mouth, and nose, and then go on to replicate and travel down the respiratory tree and sometimes the intestinal tract. The virus also spreads when an uninfected person contacts droplets containing an active virus with their hand, then touches their mouth or nose, or possibly their eyes. The virus may also be aerosolized during certain medical procedures and inhaled directly into a person's lungs, speeding the time and the seriousness of the infection. While the vast majority of COVID-19 infections are mild, if the virus reaches a patient's lungs or other vital organs and they require hospitalization, even with hospital care, death is possible. So right now, we can see throughout the world and within the United States that regional healthcare systems are or may become overwhelmed by COVID-19. We see that there are mass graves being considered and being used in many areas because of how many people are dying and how rapidly they're dying. So one of the things that we want to be able to do is reduce the spread of COVID-19, and that means reducing the reproductive ratio. And we only have a few tools for doing that. At the same time that we're working to reduce the reproductive ratio, we're also working to increase the current health system capacity. In other words, we know that severe cases of COVID-19 require hospitalization in the intensive care units. So we need to increase the number of intensive care units within our hospitals. We need to increase the number of tests that are available to check people. We need to increase the amount of personal protection equipment that we have available. So we need to increase the capacity of our overall health system as we lower or reduce the reproductive ratio. So how do we decrease the spread of COVID-19? How do we decrease the reproductive ratio? Well, we can avoid non-essential travel. In other words, we don't want to take somebody who has infected by COVID-19 and have them go to an area where there isn't any COVID-19 and start infecting that area. And this is difficult without testing because many of the people who are shedding the virus, who are contagious, do not have signs and symptoms. We also have, in order to control this, we do need to have extensive community testing, and we need to have contact tracing. So we need to be able to test everybody to find out where the virus is, and then we have to follow them back to see who they've been in contact with, and then take those people and put them into quarantine to make sure that they don't infect others. When in public, we need to have physical distancing. That's at least 6 feet and likely more. We need to constantly wash our hands to make sure that we're getting rid of any of the virus that's on our hands before we touch our mouth or face. And we want to cover our face, our mouth, and our nose, and perhaps our eyes with a mask and potentially glasses. All of these need to happen at the same time. Physical distancing without a mask is not as effective, and certainly using a mask without physical distancing is not as effective either. Also in public, we need to regularly disinfect community surfaces to reduce the chance of picking up those droplets with our hands and then touching our face. And of course, we need to avoid touching our mouths, nose, and eyes. At home, we also need to continue to disinfect community surfaces and maintain our hand washing and hygiene. Now the question is, when can we stop all this? Well, from a community health perspective, we can stop when we have a vaccine, and that vaccine has been distributed to the majority of the population. Then the virus will drop down and hopefully eventually die out. If it mutates on an annual basis like influenza, then we're going to need to revaccinate the population as the virus mutates. We do know that some people who have recovered from the virus have different levels of immunity. Some have high levels of antibodies, some have medium, and some have low levels of antibodies, and some have none. This indicates that immunity is certainly possible, but we don't have the tests that are going to allow us to there are not enough of them to be able to tell how many antibodies a person is carrying, and they're not easily distributed at this time. This leads us to a number of questions. Can we maintain a stable economy and take protective measures to reduce the reproductive ratio? And that's a question that we can see the answer being played out around the world and within the United States on a state-by-state, sometimes county-by-county basis, depending on what the governors of each state have decided. We'll see some states that are removing any type of restrictions and physical distancing and allowing businesses to open up. And we'll see other states that are really very, very slow about this. This is a very difficult decision to make. If we don't take protective measures, will our economy remain stable? And the answer to that is, we don't know. Probably not. Will our economy remain stable if we do take protective measures? Well, we can see that that's not the case either. So this is an incredibly difficult decision to make. We're balancing community health and economic stability, and there is really no good answer. Do we focus on community health and lowering the number of deaths until we get a vaccine? Or treatment, or the ability to trace people so that we can quarantine certain populations in certain areas. That's sort of the tact that all of the epidemiologists are recommending. And yet we have, as a result, some economic instability. Only time is going to tell which one of these plays out to be better.